Thank you so much, Tiffany, for that wonderful welcome. I hope y'all can see me in my slides now. Let me know if you cannot. But I'm very excited to be here, so thank you so much for having me. As Tiffany had mentioned, my research is mostly around personalizing regional anesthesia in patients receiving surgery. So what I'm going to talk to y'all about today is personalizing regional anesthesia in patients at risk for compartment syndrome and severe acute post-operative pain. So I don't really have any funding or disclosures. I've been very fortunate to be funded by my department and also an Eleanor Malshore Award, sort of like an HMS and combined grant with our department. So no other disclosures for me. These are my learning objectives today, so we'll go through them one by one. The first one that I'm going to talk about is considerations when providing regional anesthesia in patients at risk for compartment syndrome. We're going to review the history of regional anesthesia in patients at risk for compartment syndrome, look at the current literature, studies, and recommendations as well. And then later on, we'll talk about the other ones as well. So what is the big dilemma? Why do we care right now? Well, our big dilemma right now in terms of this topic is, does regional anesthesia impact the ability to detect the signs and symptoms of compartment syndrome? So what is our actual question? Our actual question is, does regional anesthesia block ischemic pain? And how do we find out this balance between regional anesthesia and detecting compartment syndrome? So this is kind of a focus of what my research had been on past. And so let's use a case example to sort of illustrate, what kind of patient would come in that you might be concerned about compartment syndrome. So let's take a 28-year-old male who was on Suboxone or is on Suboxone, and he's taking 8 and 2 milligrams a day, and he has a history of heroin use. He's been in recovery for 5 years, who presents with a distal tibia fracture. Let's say it's a pylon fracture, which we'll talk a little bit about later, after an MVA. He has severe pain, mild swelling around his ankle. And this is what he looks like when you get to him. So you're thinking, yeah, this person probably has pain. So as a regional anesthesiologist, I'm like, well, if there's pain, what about a block? And so with these patients, we like to provide a nerve block for them, but the surgeon is concerned that there might be a risk of compartment syndrome. So they tell you, no, thank you. So we have to use other tools such as non-opioid analgesics in order to help with controlling the pain, and likely opioid analgesics as well. And, let's take a look at what some of these might do in the setting of compartment syndrome. So in order to do this and look at this topic, we have to have a little bit of an understanding of what the history was and the literature that's been described surrounding acute compartment syndrome and the extremity, in addition to regional anesthesia. So as a brief overview, the definition of compartment syndrome is an increase in pressure within a compartment that leads to a compromise of the blood flow within an enclosed space. Dr. Volkmann was noted as one of the fathers of orthopedic surgery, and he first described it in 1881. The complications of acute extremity compartment syndrome usually include irreversible tissue ischemia, loss of limb, rhabdomyolysis to the point where people need dialysis, and death. And so the time to diagnosis does affect morbidity and mortality, and is therefore very crucial. And the treatment for it is a surgical emergency, and you get a fasciotomy, as you can see here below. So what are some of the signs and symptoms if you were to encounter a patient with one? Usually what we've been described throughout our training is pain out of proportion. This is the earliest clinical indicator of compartment syndrome. However, it may not be present, and we'll talk a little bit about that as well. Other things include paresthesias, pallor, pulselessness, and paralysis. Some of these are considered late clinical findings and may be less commonly described or seen. And in order to learn about, well, who's at risk from compartment syndrome? Any of these upper extremity, even lower extremity fractures can be compartment syndrome risks, but the one major one that usually presents is a tibia fracture. And 40% of all compartment syndrome is comprised of tibia fractures. So what is, the type of tibia fracture you might see? Well, the tibia fracture you might see might be a tibial shaft fracture, which is kind of like the middle of it, and the risk of ACS is 3 to 30%, pretty wide range. Tibial plateau fracture, as you see on the top, is a proximal fracture. It's about maybe 2 to 12% incidence. And then the distal fracture, also known as a pilon or plafond fracture, is about 2 to 3% risk of incidence of ACS. And who's more at risk? So the people that are more at risk tend to include patients that are 35 years old or less. And they have an increased risk by 30 times. And why is that? That's because they usually have thicker fascia. And so, the swelling can be more and it's like more compressive. The primary inciting insult for ACS is usually an orthopedic surgical trauma, or is less likely the surgical trauma, is more likely the initial traumatic injury. But both can be possible. And early surgical stabilization, such as a fixation, may help to mitigate this risk. So there are also 4 compartments of the lower leg. All happen to be in the sciatic distribution as well. The anterior and lateral compartments are the most frequently affected. And just to note, there is also a cutaneous nerve, known as the saphenous nerve, that can also be injured in the decompression of a posterior medial incision line. However, it doesn't really contribute to these compartments. There are certain nerves and arteries that are affected in each of these compartments, which is why you can have some motor deficits and ischemia. And then brings us to well, why do we really care? Okay, well, sometimes people get compartment syndrome, things happen. Well, they have complications, as we had mentioned, including limb ischemia and also, loss of limb and rhabdomyolysis and death. But also there are legal concerns in our country. And so the rate of compartment syndrome in malpractice is about 0.002 claims per year of practice per surgeon. And so 16 claims were actually placed through and made a decision on between 1980 and 2003. 10 claims were in favor of the physician, and the 6 claims that were not in favor of the physician was mostly due to poor physician-patient communication. And within these, what they found was that fasciotomy performed within 8 hours after first presentation of symptoms was very favorable for a successful defense on the part of the physician. This is also another reason why time to diagnosis, let alone just the medical part, is also important as a consideration. So what is the evidence that regional anesthesia leads to delay in diagnosis of compartment syndrome? We have to kind of go backwards quite a bit, And so what is the evidence? Well, let's start with the compartment syndrome, the tibial shaft fracture missed because of a local nerve block. This is literally, that's the paper. So what kind of block did they get? So it was a 28-year-old male, tibial shaft fracture, got a 3-in-1 fascial iliaca block, which is, said to block the LFCN, which is the lateral femorocutaneous nerve, the femoral nerve, and also maybe the obturator. They used bupivacaine 0.5%. The patient in the PACU already had altered sensation in their foot and the lower leg. And at 48 hours, they were unable to extend the large toe, which is not in this distribution of the nerve block. The anterior compartment pressure at that time was 108, which is very, very high. And this person had a 4-compartment fasciotomy with residual deficits. So unsure, why. People thought that this might be the nerve block itself, but that's okay. And then we have another case. 18-year-old person, motorcyclist, had a road traffic accident, bilateral closed femoral shaft fractures and avulsion anterior tibial spine of the left knee. They also got an epidural as a post-op analgesic as well. And they almost had total paresis of the left leg. The right leg was free and mobile. The compartment pressure was 79, and the patient also got a 4-compartment fasciotomy of the left leg and had delayed primary graft enclosure, otherwise didn't suffer any residual deficits. But, epidural, one leg is moving, one leg is not. Then we have this idea that, well, we have to always have pain at a proportion of injury. Well, maybe we don't, because there have been described these silent compartment syndromes, relatively young patients, in this also 4 person case reports. And just to remind you, like most of these findings that we're talking about right now are all at the level of case reports. So who was described? Well, there was an 18-year-old who had a femoral diaphysis fracture, retrograde nail, had a dull ache. And that was it. And the time to diagnosis was 10 hours. There was no abnormal discomfort at the time. Then there was a 23-year-old who also had a tibial fracture injury, had 5 out of 10 pain with routine analgesics, no block. And prior to discharge the next day, he had paresis and therefore also received treatment. Then there was 43-year-old and 48-year-olds who had tibia fractures. They had, one of them even had sparse analgesics, didn't require anything, and still, at the time of diagnosis was 5 out of 10. And then, the other person was at ease with pain. And so this can still happen where you can have diagnosis of compartment syndrome without any pain out of proportion. So what about cases where ACS is recognized despite having a continuous nerve block? Well, we have some cases here, including a child, a 12-year-old male. He fell from a tree and had a tibia shaft fracture. Post-op day 1, had difficult to manage pain with IV opioids. They placed a sciatic nerve catheter 7 hours post-op. It was noted to have slightly tense and sore on palpation and with passive movement of the foot, and at 7.5 hours post-block, had severe pain of the lower leg and received immediate fasciotomies with no complications. So close follow-up. And then there was another one, also a younger person, 19-year-old female, recurrent subtalar fibrosis coalition of the left calcaneus and a Achilles tendon injury. They placed a popliteal fascia catheter for this patient, and he had a dense sensory block on post-op day 1. The catheter rate was decreased and actually discharged home with this continuous catheter in place. On post-op day 2, presented at the ED with pain. Cast splint was immediately taken off and had relief, and then they recommended removal of the nerve block, which actually the patient refused because the pain control was so good. But it really was because of the compression, and then the sciatic nerve block was removed after that. So why does compartment syndrome get missed in the setting of a nerve block? So why do we, it's good pain control, but it's because sometimes we think that's because the patient isn't considered as high risk for acute compartment syndrome. There may be a focus on, well, the block isn't working, so let's get the block to work better, and maybe not the source of the pain itself. And then there's also, as we described in those 4 cases before, is silent compartment syndrome. Sometimes people just don't have that much pain. So let's move back to our patient that we had from the beginning, the 28-year-old man male who had was on Suboxone, had the distal tibia fracture, has severe pain. So we give him, an ideal world, what we would do for this person, or what I would like to do for this person if I saw this patient on the acute pain service is I would give him multimodal analgesics, including some regional anesthesia, a little bit of opioid, and patient's happy with pain. But what happens is if we're unable to provide regional anesthesia, this patient's pain is going to increase, and this patient may not be as happy as we'd like. So why don't we, just increase the opioids then in order to try and make their pain better? Well, did you know that opioids can also lead to delay in diagnosis of compartment syndrome? And this is also, again, still at the level of case reports, but there are several cases where 4 patients who were in their 20s, 1 patient in their 50s, so above 30 years old, had injuries of the tibia, received a PCA, and it was started post-op either in the PACU or return to floor, with a time to diagnosis of ACS anywhere between 16 to 36 hours. They use a IV morphine PCA, and it wasn't a lot of morphine, but you can still potentially, mask it as well. So like, for example, just so you know, 10 milligrams of IV morphine is probably equivalent to, 1.5 milligrams of IV dilaudid. So most people had, less than 3 milligrams, most of IV dilaudid, except for one who had a lot. All these patients ended up having fasciotomies, and some of them did have some residual complications. So even IV opioids themselves, can potentially mask it. As you can see, the time to diagnosis was more than 8 hours. So now let's taking that into account with IV opioids as well. So, okay, well, now we can't really use IV opioids too much. So what do? Well, let them just have pain. At least we can catch, the approximately 3% of patients, and maybe even less, we're not really sure, that develop, compartment syndrome. If you're a part of that 97%, that's kind of terrible. In actually a very recent paper that was published in 2023 in Rapam, looking at regional anesthesia for long bone fractures in a surgical center in Florida. What they found was that usually 90% or more of their treated trauma patients received a peripheral nerve block. And so over a 10-year period, 2008 to 2018, they looked at 13,000 patients who had tibia and fibula fractures, of which 3,000 had surgery, and 2,500 of them had a nerve block with their surgery. So that was like 87% of their patients who actually had surgery after the fracture had a nerve block. The incidence that they saw was about 0.8% of all the tibia and fibula fractures had acute compartment syndrome. So that's lower than the 3% that we were talking about of having compartment syndrome. If you looked at all the long bone fractures that they were looking at, it was only 0.1% of all fractures had it. And only 2 of the people that actually had acute compartment syndrome had a nerve block that had a tibia and fibula fracture. One had external fixation. They were 60 years old. It was 16 hours to diagnosis. And another patient was 30 years old, 5 hours to diagnosis. Again, both of these did not have any long-term neuro complications. So given this, we're saying, well, unfortunately, we can't use a lot of these regional or opioids, so they're going to have a lot of pain, especially this person who is already on Suboxone. So why do we care if they have more pain, in this acute period of time? Well, there are some specific, procedure-specific risk factors for development of severe postoperative pain. But the reason severe postoperative pain is a really, really important issue is that it contributes to several things, including dissatisfaction after having their procedure, delayed recovery, immobility, prolonged hospital stay in the post-op period. And one of the things I'm interested in is chronic post-surgical pain, which can lead to patients having pain for a very long time, more than 3 months. They continue to have pain, not in the area that actually that they previously had pain if they were to have had pain. And this may, end up patients having, long-term potential for need for opioids, which is not necessarily good as well. Risk factors for severe postoperative acute pain: younger age, female sex, and preoperative chronic pain. Younger age is kind of a part of this population that may get into, that may have these tibia and fibula fractures. And so what is the benefit of regional anesthesia? Well, regional anesthesia is great, and it's true. It's because it's shown to have improved pain scores post-operatively with the potential of using fewer narcotics even after the removal if they received a continuous peripheral nerve block catheter. In one study with talar and calcaneal fractures, PCA versus a preoperative continuous sciatic or pop fossa nerve block showed a 30-fold increase in opioid consumption in the PCA group. In tibia and ankle fractures, peripheral nerve blocks were shown to have an increase in patient satisfaction, as you can see on the right, the most right. And also, you can see that the quality of postoperative pain management in the first 24 hours was also improved. And regional anesthesia may also prevent the development of chronic post-surgical pain. There are several targets in which several areas in which chronic post-surgical pain could potentially happen and also potentially be targeted. And so regional anesthesia can target certain areas, including peripheral nerve activation, local inflammatory response and neurogenic inflammation, peripheral nerve sensitization and continued ectopic activity, changes in gene expression at the dorsal root ganglion, central sensitization, descending facilitation from the brainstem, and cortical pain processing. And one of the things that is a risk factor of developing this chronic post-surgical pain and traumatic pain is post-operative pain intensity and duration. So what are the current recommendations or guidelines in regarding regional anesthesia and compartment syndrome? Again, these recommendations are kind of made at the level of case reports and now based on retrospective analyses. But essentially in 2015, Brigham published based on pediatrics is that no current evidence that the use of regional anesthetics increases the risk of ACS or delays its diagnosis in children. The use of low-dose single shot or low-dose infusion to reduce masking of ischemic pain and muscle weakness may be helpful, or excuse me, may reduce or mask. And what they really recommend is also follow-up by an acute pain service. Even in the Journal of Orthopedic Trauma, they even recommended for pain management and acute musculoskeletal injury is consider local or regional block during operative treatment of fractures and as part of post-operative multimodal pain control regimen. And a continuous catheter may be considered over a single shot as well. And while there is absolutely no, one of the more recently published as well in 2021 is that while there is no absolute contraindication as regards to the use of regional anesthesia in the setting of ACS, when ACS is in concern, some fracture patterns such as high energy injuries and surgical procedure do carry a higher risk. And I do think that's true. It's just, how to balance this risk. So back to our dilemma. So does regional anesthesia impact the ability to detect signs and symptoms of acute extremity compartment syndrome? Real question, does regional anesthesia block ischemic pain? And does a partial nerve block, which is our clinical question, does a partial nerve block also block our ability to detect the ischemic pain? And does the lower dose of regional anesthesia alter the ability to detect ischemic pain? So this was what I was interested in. And the degree to which such variations may provide anesthesia really hasn't been systematically tested, which is why I was interested in this question. So one of the studies that I did was I wanted to investigate whether a partial nerve block or a lower concentration would decrease pain perception in a human model of healthy volunteers of compartment syndrome, the lower extremity. The primary outcome that we had here was blocked and induced increase in pressure pain thresholds. And also secondary outcome was blockade of ischemic pain during a 5-minute cuff hold on their calf and looking at what their pain score was over time. Our study design was that it was actually quite complicated, but I'm going to break down. So it was healthy volunteers were recruited to our Center of Clinical Investigation. There were 3 randomized groups, including patients that got only an adductor canal nerve block alone, and everyone received an adductor canal nerve block with 1.5% mepivacaine, 10 cc's. Then the second group was an adductor canal nerve block with a low concentration of sciatic nerve block, meaning 0.375%, mepivacaine, 15 cc's. And another person the third group had an adductor canal nerve block with a high concentration sciatic nerve block, which was 1.5% mepivacaine, 15 cc's. And just to let you know, these blocks of 0.375% and 1.5% mepivacaine is equivalent to about 0.1% bupivacaine and 0.375% bupivacaine, respectively. Then we used a test of quantitative sensory testing of pain, which is a quantitative physical measure of pain that's been calibrated. And what we looked at was the pressure pain threshold, pain rated when the cuff pressure first became palpable all the way to different levels of pain from 4, 6, 8, and 10, up to 10 out of 10 pain. And ischemic pain was holding the pressure at whatever they decided was their 4, 6, 8, and 10 out of 10 pain for 5 minutes at a time. Just a brief review of anatomy, and one more time, is that the adductor canal nerve block, really is the saphenous nerve, and it covers kind of the medial portion of the leg. And then the sciatic nerve block really covers the areas of the compartments that we were talking about in the sciatic distribution of the lower leg. Also, this saphenous nerve is a cutaneous nerve that can also be injured in decompression of the posterior medial incision line. if they had to do a decompression. So what we found is that we had 42 healthy volunteers that participated in the study. 23 were men, 19 were women. And our results showed that the adductor canal nerve block actually decreases pressure and ischemic pain significantly, as you can see here on the left, but less than with the addition of even a sciatic nerve block or at the 6 out of 10 pain threshold. And on our left is where we show our primary outcome, where the graph shows the different block groups on the x-axis and the difference in the cuff pressure threshold before and after a block in the same leg on the y-axis. Notably, we see a significant increase in the cuff threshold post-block. On the right is our secondary outcome, which is the ischemic hold. And we have that different block groups on the x-axis again, and the average pain rating during a 5-minute cuff hold on the y-axis. Notably, we see that the pain scores were significantly different between the groups, but there was a significant decrease in the pain scores with the adductor canal nerve block alone, and an even more dramatic decrease with the addition of either the lower concentration or a high concentration nerve block in the sciatic distribution. Oops, sorry. So just to show you what that sustained ischemic hold looked like over a period of time, we can look at the data more closely. Here you see the average pain scores of our healthy volunteers over an entire 5-minute ischemic pain hold at the 6 out of 10 pain threshold and the 10 out of 10 severe pain threshold. You see a difference in the average difference in the pain scores between the no block, which is the black dots, and in the different groups, which is the colored dots. And the addition, what we see here is that the difference seen is the addition of the adductor canal nerve block. You see about 1 point and about 4 points in the low concentration sciatic nerve block, and about 4 to 6 point difference in pain scores in the high concentration sciatic nerve block. So based on all this information, what do we know now? The impact of nerve blocks on pressure pain and ischemic pain can be sensitively detected using quantitative sensory testing methods, as you see here with that cuff, a calibrated cuff. The adductor canal nerve block provides less analgesia to pressure and ischemic pain and may be a potential compromise to provide non-opioid regional anesthesia-based analgesia in clinical scenarios where there's a concern for compartment syndrome. And if you have, like, for example, an incision that is mostly in the medial side, that might be helpful as well. And a lower concentration, such as mepivacaine, 0.375% or bupivacaine 0.1% versus a higher concentration, which is like mepivacaine 1.5%, which is equivalent to 0.375% bupivacaine, appears to differ in the degree of analgesia provided, but unfortunately did not reach statistical significance. So there's still this ongoing debate, of, well, can we still use it, nerve blocks, or should we not? So this is still a hotly debated topic, given that giving peripheral nerve blocks routinely to patients at risk for acute compartment syndrome may or may not be like something that we desire, or the surgeons may not desire. What we noticed that what they did notice is that dilute local anesthetics, continuous nerve block infusions that can be paused, and direct targeting of sensory nerves, such as like an adductor canal nerve block, provides a sufficient steady state analgesia without impairing mental status or adequate nerve function. So there is some sort of compromise that we may have and still be able to use regional anesthesia in a way that would potentially help to mitigate, not being able to detect compartment syndrome. So looking back at our patient, based on this clinical evidence in human volunteers, non-animals, or case reports, that may provide our patient with maybe, support for the use of regional anesthesia in addition to all these other multimodal analgesics that we have. So, we can provide a little bit of regional anesthesia in the form of an adductor canal nerve block at a low concentration of a sciatic nerve block, add the opioids back as well. And maybe we can then really help to control this person's pain. So that's the end of the first learning objective. We're going to go on to our second learning objective, is Well, are there certain kinds of people that, would really benefit from having a nerve block versus not having a nerve block? So the next topic that I'm going to talk about is understand the impact of psychosocial and physical pain profiles on regional anesthesia experience. And so I, looked at this based on actually our data as well from this study. And just to go back, so what are some of the risk factors for developing chronic post-surgical or post-operative pain? And there are some psychosocial factors that really can impact this as well, including opioid dependence, nociceptive sensitivity, tendency towards pain, anxiety, depression, sleep disturbance, pain catastrophizing, somatization. Things that we can do to help, as I have circled here, is regional anesthesia. And just briefly, again, just to define like who has chronic post-surgical pain, like, or what is the definition, is that patients who have greater than 3 months after surgery or tissue trauma still having pain, chronic pain that develops or increases in intensity after surgical procedures or tissue injury, and that persists beyond the healing period. So, what does this kind of really entail, and what does the psychosocial pain profile mean? It means that trait catastrophizing, or it can include trait catastrophizing, which is like rumination, magnification, and helplessness. And there's also situational pain catastrophizing, which is like specifically to a specific procedure or event that happens, like what was your thought process when you're receiving it? And these are like validated questionnaires. The pain catastrophizing scale is a 13 to 14 question questionnaire, and the SPCS is 6 questions and takes like a minute to complete. There's also quantitative sensory testing of pain, as I had described previously, as well. And so we can use these modalities to kind of characterize patients, different patients. So what did we know? What we found from our study was that greater situational pain catastrophizing about a nerve block is associated with greater pain sensitivity, such that patients that had it was essentially situational pain catastrophe was correlated with lower forearm and trapezius threshold and tolerance, and situational pain catastrophizing was also correlated with lower cuff pressure pain thresholds at the leg at different levels of pain. And so basically they just couldn't tolerate as much cuff pressure, as much forearm pressure, or trapezius pressure as well. And interestingly, we did a moderation analysis afterwards, and we saw that the relationship between situational catastrophizing and pain sensitivity were different in males and females. As you see here, the line for the male is blue, and the line for females is green. And according to their self-rated situational pain catastrophizing, as you see on the x-axis, there were different levels of threshold tolerance and threshold and tolerance, as well as cuff pressure pain thresholds, and also like if they had different types of painful after sensations after the pinprick or temporal summation of pain, and even lidocaine procedural site injection before we place the nerve block. And what you see here is that this line, like for example, in the first 3, you see that with males, like it was a lot steeper than in the females. And we also included qualitative research because what we thought was that, there might be something that people are trying to, that might be different between patients, and what are they actually interested in when they're getting a nerve block? Yes, this is a set of healthy volunteers that are volunteering to get a nerve block. However, what the interesting things that we found was, patients were like really wanted to feel engaged in watching their nerve block. They were curious about getting a nerve block, and also before even getting it. And then, they also were interested in the intraprocedural education and reassurance during it. And they said, things like, well, I was really interested in watching the ultrasound. And it was nice that, the study staff was able to tell me more about it. So that brings us to our last objective here, which is that, let's assess the impact of providing pre-procedural sedation versus intraprocedural education and reassurance for patients receiving a peripheral nerve block. So how can we personalize the regional anesthesia experience for patients? Well, what kind of patients might desire sedation. What kind of patients might desire intraprocedural education and reassurance? You might say, well, just give everyone sedation, who cares? Well, some people actually might feel that they're like having more involvement in their care will increase their satisfaction potentially, might, decrease their pain. So what we did was we recruited patients that were getting a single shot nerve block for surgery. Then we sent them psychosocial questionnaires, as we had mentioned, such as the pain catastrophizing scale. We performed some quantitative sensory pain testing of pain as well. We randomized them based on high or low pain catastrophizing, and we randomized them to then have sedation or excuse me, let me go back. So they were either categorized as high or low pain catastrophizing based on their initial screening survey. Then they were randomized to either get sedation or intraprocedural education reassurance. And then from there, we did that quantitative sensory testing of pain. We gave them their nerve block, and we also did the injection site pain rating as well. Then we asked them about, how their experience was with the nerve block. Preliminary data from 42 patients that we've recruited. The average age was about 63 years old. And the medications we used for sedation included midazolam and fentanyl. Everyone got midazolam and some level of fentanyl. And then or education reassurance as well. And 52% were males, and 21 of them were randomized into the sedation group so far. And so 23 were in the education and reassurance group. And the mean actual pain catastrophizing in the low catastrophizing group was only 4.5 with a range of up to 54. And the mean in the high pain catastrophizing was 17. Our cutoff was 10 between the two groups. What we saw was that ANOVA revealed a significant interaction of treatment group with pain catastrophizing, as you can see on the left side, where if they were in the high pain catastrophizing group, they were actually more beneficial to get sedation. And it was kind of the opposite in the low pain catastrophizing group, though it hasn't reached statistical significance. If you wanted to see the moderation analysis, this is what is noted on the right, where basically they rated their pain much higher in the education and reassurance group in the high catastrophizing group, but rated it lower if they got education in the low pain catastrophizing group. Lastly, what we found was that we looked at what is their patient satisfaction with the procedure, and patient satisfaction with the procedure was kind of high, pretty much regardless of what happened, except for it was a little bit, it was lower, in the education group when it was in the high catastrophizing group as well. But interestingly, if this was our, primary outcome, we may not have seen really much of a difference. So what are our take-home points? This is the end of the talk. So regional anesthesia can be safe in patients at risk for acute compartment syndrome. Greater situational pain catastrophizing may lead to greater pain sensitivity and greater postoperative pain. And the regional anesthesia experience varies between patients, and some may prefer actually having intraprocedural education reassurance versus sedation. So I want to thank all of y'all for listening today. And I do want to thank definitely Brigham and Women's Hospital and all their support that they've given me, especially the Department of Anesthesia and Perioperative and Pain Medicine. Dr. Kristen Schreiber has been an incredible mentor to me throughout this entire time, all the way from residency through fellowship and as an attending. And then also my team of wonderful mentors, Dr. Philip Lurk, Kama Vlaskov, and also Jose Zabalos. And then our team of scientists and research assistants, including Jenna, Michaela, Corinne, Sheila, Patrick, and Martin. Sheila's actually a fellow right now in regional anesthesia and will be an attending at Brigham next year. So thank you guys so much.